for today's speaker. Our first speaker is Dr. Jordan Dunitz. Dr. Dunitz is the director of the Minnesota CF Center and Adult CF Program and the medical director at the Center for Lung Science and Health Clinic in Minneapolis. His main clinical interests are cystic fibrosis and lung transplantation. Dr. Dunitz has served as site primary investigator or co-investigator for a number of phase 2 and 3 trials for new medications for CF patients, including ivacaftor and lumacaftor ivacaftor, and has participated as a co-investigator for numerous other phase 1 through 3 trials for new CF and transplant medications. Please help me welcome Dr. Dunitz, who will speak on curing CF. Are we there yet?
Morning. I'd like to thank the organizers. Oh, I think we got 2 microphones on. Thanks. I'd like to thank the organizers for inviting me and all of you for waking up this morning and coming to the, it's like Jimi Hendrix. That's worse. Is that working? All right, here, we'll give it a whirl. Again, I'd like to thank you all for coming and the organizers for inviting me. My topic today, curing cystic fibrosis, are we there yet? Isabel asked me to, quick disclosures. As mentioned, I've been involved in a number of clinical trials. I also have funding from the CF Foundation for our center grant and also as the chair of the center committee. Isabel asked me to mention a few words about my involvement in CF, how I get started, and what I do. I am the adult program director and center director at the University of Minnesota. I've been in Minnesota since 1988. Do we have a, there we go. Not working. So Minnesota is the kind of pink state up at the top. I point that out because I grew up in New York, and at age 25, I probably wasn't quite sure where Minnesota was, but now having been there for 30 years, it's pretty clear. I have 2 children, one who went to school at the University of Maryland, the other University of California, Davis, and the number of people that didn't know where they were actually from was staggering, and including one that asked my son, as a Minnesotan, if he thought of himself as a Southerner. We can see Canada from here. I started out actually as a lung transplant physician. I finished my fellowship, pulmonary fellowship in 1993 and was originally only involved in lung transplant. At that time, our pediatric program took care of all of our adults. In 1999, Carlos Mila, who I think many of you are familiar with, asked me to start the adult program at the University of Minnesota. Carlos taught me how to care for CF patients, and the rest is history. At Minnesota CF Center, we take care of 550 patients. We have 360 adults, ranging anywhere from 18 to 68 as our oldest patient at this point. We have 110 patients who are more than 40 years old, so we have a kind of old crowd or older crowd. In addition to the 360 adults with CF, we have 50 post-transplant CF patients, the majority of whom I manage, so that I can manage both their CF issues and their transplant issues. Fortunately, I have 3 other physician colleagues that help me manage the other 360. We also care for 140 children in our pediatric program. Our genotype array is pretty similar to most centers. So about half of our patients are delta F508 homozygotes. Another third have 1 copy of delta F508 and some other gene, and then about 10 to 15% are non-delta F508 patients. About half of our patients have diabetes, probably a little bit higher than the national average, maybe because we have a slightly older population. And looking at the outcomes in our patients, our lung function, our BMI are in the upper quartile. And we'll have some guesses about why the lung function are in the upper quartile. I have a pretty clear idea about the BMI. If you go to Minnesota State Fair, we are willing to fry anything. Not only will we fry anything, we will deep fry many things, and we will even put them on a stick to deep fry them. But I think the real answer is this booth here, and I don't know if you can read it. It's called Big Fat Bacon. So we have the Big Fat Bacon booth. And so Minnesota, we hold our fair in the 1 week of nice weather in Minnesota. The rest of the time, you can tell summer from winter because of whether or not the kids have shorts on when they're walking the dog. So, better get to work. Curing cystic fibrosis, are we there yet? If some of you are the type that read the last chapter of the book, no. We aren't there yet. But I think we can see it from here. I think that there are some amazing new medications in the immediate horizon, and in just beyond that, really some potentially curative approaches to CF. So I think that this is a time to be very optimistic as patients, as parents, and as providers. A quick outline of what I'm going to talk about today. First, I'm going to talk about CF pathophysiology, so a little bit of background on CF and how the disease develops. Then we're going to look at the pipeline, some of the drugs that are going to be available now and are going to be available in the near future. So a little bit of the history of the pipeline, then kind of make our way down the pipeline, antibiotics, some sodium channel modulators, we'll talk more about that, correctors and potentiators, some challenges and opportunities with those drugs, and then some approaches to rare mutations. I'm going to start hopefully fairly basic because my understanding is that there's a broad array in the audience. I apologize if some of what I'm saying is just clear review for you, but I want to make sure that once we get to the medications, as we get through this, we have everyone at the same page by the end of the hour. So there will be a little bit of a subliminal message passing through the talk here and there. Pathogenesis of lung disease and CF. Pathogenesis, how does CF develop? So 3 or 4 decades ago, what we knew was CF patients had bronchiectasis, so thickened airways, airways that are widened in some place, narrowed in some place, blocked, leading to cough and sputum. And that's what we knew. We knew what a CF patient looked like, clinically what they looked like, what their disease was, but we didn't have any idea how they got there. Over time, we learned that there was a series of events causing bronchial obstruction, so the airways get narrowed, infection and inflammation, leading to this bronchiectasis with cough and sputum. And each of these events seems to cycle back on each other. So the obstruction predisposes you to infection, which causes further obstruction. The infection leads to inflammation. The inflamed airways get narrowed, leading to further obstruction. So all of these different components of CF, sort of the end parts, kind of feed back on each other, and each step kind of worsens the steps before. But we didn't know how we got here. We didn't know what was the sort of primary cause of the obstruction leading to the other events. Until 1989, when the CF gene, the CFTR gene, or the CF gene was identified, the CFTR. This actually started some very important science. This was one of the first genes that were identified associated with the disease, and actually, in very important ways, led to the entire genome project, where we've looked at the entire genome at this point. So we then knew the top and the bottom. So we knew there was a defective gene, and we knew that there was obstruction, infection, inflammation, and bronchiectasis. But still, we didn't know what came in between. With the identification of the gene, we figured out that the gene coded for a certain protein, something called the cystic fibrosis transmembrane conductance regulator. And that's sort of, from a scientific standpoint, a kind of vague name. Basically, it's, well, we kind of know it does something with electrolytes somewhere, not really what or how. So we knew the gene, we knew the protein, but we didn't actually even entirely know what the protein did. Over time, we've learned that the CFTR is a chloride channel, and the abnormalities in the chloride channel lead to an abnormal airway surface milieu. So the area just between the airway and the air in those breathing tubes is where the abnormality is. Just where the cells touch the air in your airways is really where the majority of the problem lies in cystic fibrosis. So if you look, it doesn't work. I'll give it one more try, No. All right. The picture on the right is a normal airway cell. So if you look at an airway cell, the cells that line the airways, The yellow kind of square is the cell itself, and on top are those little lines which are cilia. And so there are cilia on the top of the airway cells, and there's a water layer that goes up to the top of the cilia, and then that little green blob is mucus. And even people with normal lungs have a little tiny bit of mucus lining their airways. When you breathe stuff in, dust and germs, all the junk you breathe in the air all the time, it gets stuck in that mucus. And the point of the cilia is to wave it to your central airways so you can cough it out. And all of us, CF or not, cough periodically to get that junk out of the airways. In the normal situation, that water layer comes all the way up to the top of the cilia. So it's sort of the mucus floats like a boat on the top of the just above the cilia. So when the cilia wave, the mucus kind of floats on the fluid level like a boat into the middle of the airways. In cystic fibrosis, that water layer is shortened. There isn't as high a water layer. And so instead of the mucus floating above the cilia, it's stuck in the cilia. And when they wave, it kind of moves back and forth, but it's just stuck there. So the germs that you breathe in, the dust that you breathe in, is stuck right up against the airway. Because of that, it brings in inflammatory cells that will try to get rid of those germs. And the inflammation, while it's designed to get rid of the germs, also damages the airways, leading to the bronchiectasis. So the whole goal here in treating CF is to try to reestablish that water layer. So,
Clicker to the next slide.
Yes.
Laser pointer.
Oh.
The red line in the middle. That's not.
Oh.
Oh, you brought your own clicker.
Oh no, this is the clicker that was here. There's a laser pointer though. All right. So just a quick kind of review of what we're talking about. You've got the CF gene, and then an RNA, a protein, and the channel. Another way to think about a gene is if you were building a car, you would have a set of blueprints for the entire car. So that book of blueprints would give you a Pinto or whatever. So hopefully something better than a Pinto. So that book has the entire blueprints. But one page is the door, and one page is the engine, and one page is the seat. So the way I think of it is the DNA is that whole book of blueprints. RNA is that page that has each of the parts. So the RNA codes there are different RNAs that code for each part of the cell, or a page in that book of blueprints that tells you how to make each part of the car. So the guys in the door department take that door RNA and lay it on the table and make the door. And so the door is the protein, okay? So you've got the big book of blueprints, the individual blueprints for the different parts, and then the part that you've built. And so you build that part until it looks like a door, or in our case, until it looks like a CFTR channel, a channel. And this is a channel in the upper layer of the cells, and chloride ions can move back and forth through that channel. And when ions, whether we're talking about chloride or sodium or any other ion, when the ions move, water tends to follow because they want those ions to be a certain concentration. So the more ions that go out, the more water that goes out. And so by having these ions functioning, you can maintain that water layer. So we're going to look at a quick video from the CF Foundation to try to put this whole thing together. And to tell you, it goes kind of quick, so I'm going to tell you what we're going to see. We're going to go down the airway into a cell, and first we're going to go into a normal cell, and we're going to see the mucus on the top and sitting on top of the water layer and moving as the cilia move. We're going to see normal channels moving chloride and sodium through. We're then going to go back and look in a CF a CF cell, and see that those channels don't work and that the mucus lays down and gets stuck on those cells. And I'm going to try to talk over this. So we're looking at the tongue here and the uvula here. We're going to go, oops, sorry. Oh, I hope I'm going to do this. Yeah. All right, there we go. So going down the trachea, through the vocal cords, now down the trachea, heading into the airways. So these are the airways. We divide into the left and right lung, but now we're going to go right into the cell lining the airway. And you see the airway lining cells and the cilia moving back and forth, and that mucus, the green stuff, is floating on that water layer, waving to the center so you can cough it out. Now we're going to go into the cell, and these are the chloride channels. So these are the CFTRs, and you can see the little yellow dots. The chloride are moving through the channels, maintaining that water layer and holding the mucus at the top of that water layer. So maintaining an adequate water layer above the cilia. On the other hand, if we look at a CF cell, what you'll see is that the chloride can't move through those channels, okay? Those channels are blocked. So you don't have any chloride moving through, so it's not pulling the water through, and so you've lost that water layer. And what you'll see is that water layer is gradually shrinking, and the mucus sits down on top of the cilia, and the cilia can no longer function. So you can't wave the mucus out of your airways. So the airways get blocked with mucus, leading to infection, inflammation, and damage to the airways. So the CF Foundation has developed a series of drugs with scientists all over the country and pharmaceutical companies, developed a whole series of drugs to try to approach CF. Anywhere from medications to help with nutrition, anti-infectives, things to treat the infection, things to reduce inflammation, things to help clear that thickened mucus, medications to try to bring back that water layer. Even if you don't do it directly through the channel, can you pull water back into that layer to float that mucus back up above the cilia so we can wave it out? And then all the way up to the point of actually addressing the abnormality in CF itself, fixing that CFTR, fixing that channel. So you'll see that along the bottom, it tells you where along the way we are. So preclinical, where it's just trying to develop the drugs themselves, looking at them in non-human models, looking at them in animals and petri dishes. Phase 1, where you just look at a small number of patients to make sure the drug is safe. Phase 2 is usually a combination of safety and trying to figure out the optimal dose. Phase 3 is then looking at it in large populations to see if it's truly effective and truly safe. And it goes from there to FDA approval to available for patients. And there are different drugs all along the spectrum in each of those areas. Because you participated in trials, we have a whole slew of medications. So we have the inhaled tobramycin to treat infections, inhaled astrinam or Caistin for infection, Toby, a kind of more convenient form of tobramycin. We've got pulmozyme to thin out the secretions and reduce the bronchial obstructions. We've got hypertonic saline that by breathing that high salt saline, it brings that water layer back up and helps to reduce bronchial obstruction. And then azithromycin, or ibuprofen to reduce inflammation, and azithromycin that probably reduces inflammation but may have an impact on infection as well. And as we make our way up the pipeline, we're getting closer and closer to actually addressing the abnormality in CF itself. And more recently, we've gotten Kalydeco or ivacaftor to fix the channel in people with specific mutations such as G551D. And more recently, Orkambi to try to actually correct that abnormal channel in people with the Delta F508 homozygotes. So with your help in clinical trials, we have this whole slew of ways to address cystic fibrosis. And by addressing the highest points in this cascade, we will hopefully prevent the injury that happens on the way on the lower end. So over the past 60, 70 years, there's been dramatic improvement in survival in CF. I mean, back in the 40s and 50s, the kids rarely lived through infancy. Then with development of CF centers and development of better enzymes and better understanding of nutrition, there was a marked improvement. In the 60s and 70s and the 80s, there were some new antibiotics that could address some of the infections patients commonly get. And then since 1990 on, this is the period where we've really developed these CF-specific medications, the Toby and the pulmozyme, and then more recently the Orkambi and Kalydeco. So if we look as we go, we've had a whole series of drugs that are getting closer and closer to addressing the underlying cause. I do want to make our way now through the pipeline. And while we're all excited about the drugs up at the top, the kalydecoes, the orcambis, the drugs that actually fix a channel, the reality is that we need all of these drugs. We still need all of these medications and will for quite some time. No matter how effective these drugs are up at the top, many of our patients already have damaged airways. And while these will probably prevent more damage from occurring, may fix part of the damage, it is likely they will not be able to fix all the damage in many of our adults. And so we're going to need to combine these with a lot of the traditional therapies. So while this is the area of greatest excitement, all these pieces of the pipeline are important for us to provide good care for our patients. So anti-infectives. They've been working on inhaled levofloxacin for quite some time. The more options we have for inhaled antibiotics, the better. Some people don't tolerate or find some of the current antibiotics no longer effective. So the more options we have for treatment, the better we can help manage our patients. So Geller and Associates in the American Journal of Respiratory and Critical Care Medicine, 2011, published findings looking at 151 patients in a randomized double-blind placebo-controlled trial. These are one of these fancy trials where half the patients get the drug, half the patients get a placebo, and no one knows who got what, so we can assess the response in a fair, objective way. It was a 28-day trial where half the patients got placebo, half the patients got inhaled levofloxacin for 28 days. And what he found was what the group found was an 8.7% increase in FEV1, kind of similar to what we've seen in a number of the inhaled antibiotics, decreased Pseudomonas density, and a decreased need for antibiotics. So what looked like a very effective drug for us. Elborn and colleagues in 2014 published in the Journal of Cystic Fibrosis an open label trial where they compared levofloxacin to tobramycin, so inhaled levofloxacin versus inhaled tobramycin. 282 patients. Because it was hard you can't mask what the patients are getting, it was an open label trial. So patients knew what they were getting, but it was randomized. So half the people got tobramycin, half the people got Levaquin. What they found was there was no difference in FEV1 or number of exacerbations. And no difference may sound frustrating, but that's actually what we were looking for. We were saying that the way the study was designed was called a non-inferiority study. So they wanted to say, we know Toby is a good drug. Is Levaquin at least as good? And what they found was that the inhaled levofloxacin was at least as good. And in certain situations, it might even be slightly better in that the people that received the levofloxacin had decreased hospitalization and improved respiratory symptom scores with inhaled Levaquin. And I thought this was all I was going to say about Levaquin until I opened my email yesterday. And that's the problem with PowerPoint. It used to be you made slides, you had to submit them 2-3 weeks before the talk and you were done. Well, I opened my email yesterday to see that they had released another levofloxacin study. This was Patrick Flume and colleagues in Journal of CF. This is actually not in print yet, but just available in electronic copy. There are 330 patients, another randomized, double-blind, placebo-controlled 28-day trial. And this time they found no difference. And when you design these trials, you have to say, what is your primary outcome before you start the trial? You have to, otherwise you can kind of monkey with the way you do your trial. So you have to say, what am I looking for? What is the important thing? What is the goal of my trial? And the goal of the trial here was to see if there was a reduction in exacerbations. And they actually found no difference in exacerbations, which is their primary endpoint, or the time to needing antibiotics using levofloxacin versus placebo. There was a small improvement in FEV1, 1.3%, and there was a decrease in the Pseudomonas density. When you randomize patients, you hope that the group that got the drug and the group that got the placebo were the same, but you don't know that that's going to happen. You just sort of roll the dice for each patient. And it appears that the two groups may not have been the same, and it may be that the levofloxacin group was actually a sicker group than the placebo group. Because if you look in the year prior to the study, the patients that received levofloxacin had more exacerbations on average than the patients that got placebo. So we're going to have to see exactly what we conclude about this study. I suspect it'll be presented in the next National CF meeting. Inhaled levofloxacin is currently approved in Europe and Canada. I think that this most recent trial was an effort to get it approved in the United States. And the response here is still unknown. More recently, or I'm sorry, not more recently, but in addition, we're looking at another inhaled antibiotic, something called amikacin, in the same class as tobramycin, but works a little bit differently and is delivered a little bit differently. And what we found so far with the inhaled amikacin is the reduced sputum density, increased FEV1, and again seems to be comparable to tobramycin. Now this is a drug that's good against Pseudomonas, but we're also interested in a bug that's hard to treat called mycobacteria. And so there are still some studies pending on the mycobacteria. This is not approved yet, but we're hopeful that we'll be able to add this to our armamentarium. But in terms of anti-infectives, the drug I'm most excited about is something called gallium. Gallium kills resistant Pseudomonas. It works in a very different way than any of our current antibiotics. So it's possible that this is going to be something that we can use in patients where our other antibiotics are no longer effective. It works against bacteria and biofilms. In cystic fibrosis, patients' Pseudomonas and a number of their bacteria grow in biofilms. It's sort of an organized colony where they form this slime that actually protects them from antibiotics. They sort of form this coating so the antibiotics can't get to the bugs. And this is, the gallium is even effective in patients. I'm sorry, it's effective against biofilms. We don't know if it's effective against patients yet, that's what we're trying to figure out. But in the dish, it's effective against biofilms. It's also, it has the advantage of it's already FDA approved. So it's already gone through all of the safety studies because it's used for something completely unrelated to CF and completely unrelated to antibiotics. People that have dangerously high calcium levels, gallium can bring the calcium levels down. So we've sort of gotten over that first hurdle of safety, and now we can just try to figure out if it's effective. And there's an ongoing IGNITE trial, phase 2 trial currently underway, where you get 5 days of continuous infusion gallium, and the endpoints are PFT, Pseudomonas density, and symptoms. And this is an ongoing trial. We're enrolling patients right now. I don't have the results, but it is exciting that we have some new potential classes of antibiotics. I'm going to skip over anti-inflammatories because Dr. Taylor Gusar has an hour to discuss inflammation. It is incredibly complicated, and I'm going to let her take the hour and just jump up to restoring airway surface liquid. So we talked about the need to reestablish that water layer to get up to the top of the cilia to get the mucus to float out. And there are a number of factors in maintaining that water layer. Part of it is the CFTR, part of it is the chloride channel, and chloride secretion adds water to that layer. There's also something called ENaC, or a sodium channel, so it's a different electrolyte, and that kind of works in a different way. The chloride is going out, the sodium is going in, and when the sodium goes in, the water layer shrinks. And it turns out there's an interaction between the chloride channel and the sodium channel, where the chloride channel, the CFTR, the CF channel, actually works to partially control that sodium channel. And when your chloride channel isn't working, your sodium channel you're actually overactive. So not only are you not secreting the chloride to bring it up, the sodium channel is working harder to bring it down. Okay, so it's sort of a double whammy in that the chloride's not going out and the sodium's going in even faster. And these channels work together in a normal situation to regulate the fluid layer. You don't want it too high, you don't want it too short, but in CF, they're not regulated properly, so too much sodium is going in, not enough chloride is going out, and your water layer shrinks. So looking here in that CF, in the CF cell, this is kind of what we're trying to demonstrate is this big yellow arrow. Usually there's a little yellow arrow, a little sodium's going in. In the CF patients, there a lot of sodium's going in, bringing down that fluid layer. Now, whenever you take sodium out, you have to take chloride out, or you have electrical problems, or you'll short out or something. So, so the chloride actually has other ways to get out, but the problem that we're trying to demonstrate here is that too much sodium is going into the cell, bringing down that water layer. So there's a new medication or a new compound. It's not, I guess it needs to be approved before it would be a medication, but it was called P1037, and then Vertex VX bought it from I think it was Perion, and so now it's VX371. So you may have heard of it as P1037. VX371 is the same thing. All the medications first have a letter and a number, the letter indicating the company, the number is just sort of the number in their compound library. And then it gets, once it gets a little further down, it gets sort of a name that's usually very difficult to say. Then when it finally gets on the market, it hopefully gets a name that's easier to say. But anyway, right now, this is just a letter and a number. It hasn't even gotten to the point of a hard name. This is an inhaled medication What's exciting about VX371 is it's mutation independent. We know, and we'll talk a little bit more about it in a few minutes, that Orkambi and Kalydeco are mutation dependent. You have to have a specific mutation for them to work. This is mutation independent. This should work almost no matter what mutation you have. Actually, this should potentially work no matter what mutation you have, because instead of trying to get at the chloride channel, instead of trying to make the chloride channel work, this medication is trying to make the sodium channel not work. Okay, this is inhibiting the sodium channel, so you're not taking the sodium out of that layer so that you're not shrinking that layer. So this is a sodium channel inhibitor. And so we're looking at it in a phase 2A study. This is an ongoing study. It's actually finished recruiting, and they're just completing the study. And the clean CF is patients with any mutation. But they're also looking at it to see, could it make Orkambi work better? We are excited about the results with Orkambi, but they didn't quite give us the boost that we were hoping for. So if we can make the chloride channel work better and block the sodium channel, maybe together we can have a greater impact on those delta F508 homozygotes. And this trial is actually currently enrolling. So unfortunately, today I don't have any results on either of these trials. They're still ongoing. Next year or the year after, we'll hopefully have some exciting data. So let's get up to CFTR modulation, the area that has recently led to the most excitement. So we know that there's about 2,000 different mutations in the CFTR. Fortunately, these 2,000 mutations actually probably work in 5 or 6 different ways. So if we look at a normal cell, a normal airway lining cell, what you've got is a nucleus down here where you've got your DNA and then your RNA, and then you form a protein, and the protein actually starts as a long chain of amino acids. It's like a long piece of yarn. And it gradually folds until it forms something that looks like a channel from those cells we saw before. And a way I've sort of like to think about it is, if you're knitting, you can have, I'm from Minnesota, so we all have to knit. If you've got a long piece of yarn, a whole ball of yarn, it's just a big long string. It doesn't look like anything. But if you've got a pattern, you can knit that into a sock or knit that into a sweater or a hat or whatever it is. So you're taking that long string and you're folding it up just right so that it forms something that looks like a channel. Although if your pattern's not right, it may not look like a sweater or it may not look like a sock. So you've got to have the pattern, that RNA, to tell you exactly what sort of thread you're supposed to have so that you can fold that into your channel. So in a normal cell, it folds into a channel, and chloride can move through the channel here. In certain mutations, things like nonsense and frame shift, and those details are not important for this discussion, that you don't get any, so the green is the protein that's sort of making its way up to being folded till it finally forms a channel. When you have, in the type 1 mutations, you don't have any green at all. You don't form a good enough RNA to make any chain at all. So you don't form any protein at all. So you have no protein, and so there's no protein on the at the surface. In the type 2, and that's the delta F508, you form a protein, but it's abnormal. And the cells have a very specific quality control system so that if that protein doesn't look normal, the cells get rid of it. And so the cells get rid of it, it never gets out to the surface. It's not folded properly, it's a bad protein, and the cell says, this is no good, we want to get rid of this because it's not working right. So you have no protein up at the top, no CFTR. The type 3 is a block in regulation like G551D, the group that is getting the ivacaftor. And what you see is the channel folds, gets up to the surface, but you don't have a path all the way through. The chloride can't get through. These channels are regulated, so they can be open and can be closed because you want just the right amount of chloride to go through. So sometimes the channel is open, sometimes the channel is closed. In the normal situation, oops, sorry. So in the normal situation, the channel is sometimes open, sometimes closed. And in the G551 and the other type 3s, the channel is always closed. There's a problem with regulation. You can't get it to open when it needs to. The type 4 is an altered in conductance in that it has a channel, but it's just not a very good channel. So some chloride gets through, but not enough. Type 5, and actually they've now divided type 5 into type 5 and type 6. You've got channel, it works fine, there just isn't enough of it. In type 5, I think you don't make enough, and in type 6, you make enough, but it falls apart too quickly. And so you don't have enough out there because it degrades too quickly. But 5 and 6 can kind of be put together because the bottom line is you've got a working channel, but you just don't have enough. These two tend to be milder mutations because you do have some chloride flow. With these, you don't have any chloride flow, so they tend to be more severe mutations. So we're all probably familiar with ivacaftor, the drug that was developed for the G551D mutation. But I do want to just go over the results a little bit for the discussion we're going to have afterward. So another quick video. And in this video, what you're going to see is that this is that thread. This is that long amino acid chain that's going to fold into a protein and then go to the surface of the cell. And initially, you'll see that chloride doesn't go through until this purple blob comes on it, which is ivacaftor, which opens up the channel and lets the chloride go through. Oh, I've lost my... There we go. So here it is, a long string that knits or folds into a channel. And you'll see the channel is going up into the surface, but the yellow dots, or the green dots are actually sodium going the other way. The yellow dots couldn't go through, but the purple blob, that ivacaftor, opened up the channel, so now your chloride can go through. So you've got channel on the surface with G551D, it's just closed. Ivacaftor opens it up, so the chloride can then flow through. And the reason we know this is if we've done a placebo-controlled trial. And the patients, this is the chloride movement in patients getting ivacaftor. So we've looked at placebo, patients that received placebo, and then patients that received ivacaftor. And this is the sweat chloride. So this is the chloride moving through. And you'll see that there's a 50-point drop, almost a 50-point drop in the sweat chloride. Or if you think about the way we usually think about sweat chlorides, we know that when you get your sweat test, if your sweat chloride is above 60, that's consistent with CF. And so this is our 60 mark. And our patients that got both the placebo patients and the ivacaftor patients, before they got the medication, their sweat chloride was around 100. Patients that got placebo stayed around 100, while people that got ivacaftor, it dropped down to about 50. So it corrected or partially corrected the sweat chloride. It went from clearly a CF diagnosis to what we would call an intermediate value. And you have to remember that these patients only had one copy of G551D, so we were actually only fixing one of their two genes. The other gene wasn't being corrected. So we've only corrected half their genes, and we are halfway there. Again, the other things that are sort of clinically more important to us, you know, fixing sweat tests is cool and fun and exciting, but really what's important is how do you feel? And so we're looking at an improvement in FEV1. So with the ivacaftor, there's a 10% improvement in FEV1. A smaller portion of patients going without exacerbation. So these are the number of people that did not have an exacerbation. And there are a greater number who received the ivacaftor than the placebo. This is actually a symptom measurement that we use in CF patients called the CFQR. And patients had fewer respiratory symptoms when we were receiving ivacaftor and actually more weight gain. But this is a 48-week trial. And the question is, well, it worked for a year. Will it work for years and years? Can we count on this to work indefinitely, or is this more of a temporary thing? And so they've gone on to look at what happens with long-term use of ivacaftor. And so these are patients receiving ivacaftor, and these are patients who got placebo and then got ivacaftor. And what we found was both the people that got it all along and the people that had placebo and then were switched to ivacaftor, they had about a 10% improvement. Oops, my goodness. Had about a 10% improvement in FEV1 that lasted at this point for 3 years and presumably will continue. The next question is, well, it improves things, but will it have an impact on how quickly they decline? So this is looking at the rate of decline of lung function. We know that people with CF, their lung function declines over time. And this is looking at people on ivacaftor, the rate of their decline, versus the patients with delta F508 who are not receiving ivacaftor. And what we see is that these two lines increasingly separate. And so the people who are not getting ivacaftor have a more rapid decline, or said in a more positive way, the people receiving ivacaftor, it not only increases lung function, but it slows the decline. Looking at hospitalizations, there were fewer hospitalizations even with longer-term use of ivacaftor. And the weight gain we see continues at least out to year 3. So not only does this drug work in the brief 1-year trial we looked at, but it appears to continue working long-term. The next drug I want to talk about is Orkambi, or the combination of lumacaftor and ivacaftor. And this is for the delta F508 mutation. So these patients, they don't get any channel out to the surface. So what lumacaftor does is it stabilizes this channel so that it can get all the way out to the surface. But once it gets out there, it's actually still closed. So then the ivacaftor, so it looks more like this, but then the ivacaftor opens it up. One more quick video. Here what we're going to look at is a normal channel that goes out to the surface and chloride flows, and then a delta F508 that falls apart. Then followed by a corrector and a potentiator that opens it up. So this is a normal channel, it goes out to the surface of the cell, and now chloride is purple in this one, but the little purple dots are going through fine. Next we're going to see a delta F508 where the delta F508 forms, but it's not stable, so it falls apart. It never gets out to the surface. And so now if we add lumacaftor, the corrector, you've got the channel. The lumacaftor stabilizes it so it doesn't fall apart. It can get out, but you see the purple dots, the chloride still isn't moving through. And so you add the purple dot, the ivacaftor, the potentiator, and now the chloride can flow through. So you've got a corrected and potentiated delta F508. So now you've moved to a functioning channel. And again, the lumacaftor-ivacaftor combination, or Orkambi, was studied in a large randomized double-blind multi-center trial. And they actually, when they did this trial, they looked at a couple of different doses. They looked at lumacaftor 400 milligrams twice a day with ivacaftor 250 twice a day, and then a bigger dose of lumacaftor but once a day versus ivacaftor twice a day. Turns out that this is Orkambi. This is the drug we're now using. One thing that was important in the study to remember, and those of you who are either taking or have family members taking Orkambi, is that when they did this trial, all of the patients remained on all of the standard medications. So even though this helps the channel work, you still need your pulmozyme and your bronchodilators and your inhaled antibiotics. This isn't an opportunity to stop them. I'll tell you that many of my patients have tried and it doesn't work. You get sick. You unfortunately have to maintain all of your standard therapies. This is on top of the standard therapy. But what they found was that there was about a 3% improvement in the FEV1. So not that 10% that the ivacaftor got us in G551D. And this is looking at a series of subgroups, younger and older patients, healthier and sicker patients. And it turns out that regardless of what subgroup you looked at, there was a benefit from Orkambi, and it was pretty similar. There was fewer exacerbations and fewer hospitalizations as well. They did find that people got shorter breath with the Orkambi. It does seem to cause some bronchospasm, some chest tightness, at least initially. And so they did find a pretty high rate of dyspnea or shortness of breath, at least initially when people got Orkambi. We found that using it clinically as well. Often it gets better, but not always. In an effort to correct some of these problems, there's a new corrector that's being studied, something called VX661. So something like VX809, something like lumacaftor, but hopefully something that works a little better. And what they found that it works with a similar mechanism as lumacaftor, moving the CFTR out to the surface of the cell, but it has a longer half-life, there are less drug interactions, and it seems like the patients are not getting that chest tightness with the 661. And looking at the relative change in FEV1 with looking at VX61 compared to placebo, it looks like there is a potentially a better improvement in FEV1, although the large trial is still ongoing and it remains to be seen. So the question is, why doesn't Orkambi work as well as why doesn't Orkambi work as well for our delta F508 homozygotes as the ivacaftor does for our G551D? And there's this, a couple of basic science studies that took a look at this, tried to answer that question. And these are the kind of trials that you read through this paper, it kind of gives you a headache, but I'm going to try to get us through it. And the bottom line is the ivacaftor seems to have a bad impact on the effect of the lumacaftor. So we're just going to look at this central figure. Forskolin is a drug that opens up the chloride channel. So if you've got 809, VX809, so you get that channel out to the surface of the cell, the lumacaftor. Forskolin, just like ivacaftor, opens up the channel. So this is another potentiator. It's not one we can use clinically. It's not one we can use as a medication. But in the lab, if you give cells VX809 and then give them forskolin, then this is chloride flow. The chloride will flow. It turns out if you take those same cells, give them 809 and 770, and these are delta F508. So these are cells, delta F508 cells in a petri dish. If you give them VX809, but also give them VX770, giving them the 770 seems to interfere with the effect of the forskolin. So the potentiator seems to be interfering with the effect on the corrector. And it looks like what's happening is that the ivacaftor, the potentiator, is causing faster turnover, causing quicker destruction of your CFTR channel that was fixed by the lumacaftor. So the lumacaftor fixes it, brings it out to the surface. The ivacaftor opens it up, but also makes it degrade, makes it fall apart more quickly. And what we see here is it's basically C-band is functioning CF channel. So these are patients that got either 809 alone or 809 and 7, not patients, I'm sorry, cells in a dish, cells in a dish. These are cells in a dish with 2 copies of delta F508, and if they got 809 alone, their level of corrected channel, of functioning channel, is much higher than they got if they got 809 and 770. So what we found is that the 770 seems to break down the corrected 809 channel. Even though it opens it up, even though it helps it, it makes it unstable, makes it fall apart. And so this is probably why we're not seeing that benefit with Orkambi that we saw with Kalydeco. So what are we going to do? Fix it. And the way we're going to fix it is maybe with another agent called N91115. And basically, what this does, it's an orally available agent. We always like orally available agent. What that means is it can be a pill. It doesn't have to be an injection or inhalation. And what it does is it seems to stabilize CFTR. And so it stabilizes it in a couple of places. This is the cell. So this is your CFTR that didn't work, that fell apart, that delta F508. This is one that's corrected and gets out to the surface. And it looks like this N91115, very catchy name, actually stabilizes the corrected and then stabilizes it on the surface. So maybe will inhibit that destructive effect that 770 has. And so there's a trial currently ongoing where we're adding N91115 to Orkambi and patients with 2 copies of delta F508. So we're taking patients who are getting Orkambi and adding this N91115 in a double-blind randomized placebo-controlled trial, looking at FEV1 as the endpoint, and a 12-week study with a 4-week follow-up. And again, this is currently enrolling. But we're starting to understand why the Orkambi isn't working, and now we're trying to see if we can figure out how to make it work, how to get that channel stabilized to try to begin to get those results that we got with Kalydeco and the G551D patients. So I'm getting the 5-minute sign, so we're going to skip ahead here a little bit. And when we look at the pipeline, what we see is the drugs we already know about, the drugs we just talked about, but there are a whole bunch of other things kind of more or less in the same vein, but we're hoping are more effective. So we're looking at another potentiator. We're looking at another drug that improves CFTR function unrelated to the current correctors and potentiators. We're looking at RNA repair. And then if you remember Dr. Portis's talk last night, we're looking at different ways to try to fix DNA, either in the short term and the long term. So there are a whole series of ways that we're trying to look at to correct the underlying cause of CF. It seems that each 2, 3, 5 years, we are a big step ahead of where we were. So as I said, we don't quite see the cure here, but I think there's great reason to be optimistic. And we may want to do some mixing and matching, hopefully better than this. But if you think about it, if we can take maybe your Orkambi, that works pretty well, and maybe add your N9-1115 to stabilize it, but then maybe add that other drug that's blocking that sodium channel. The whole goal is to get that water layer up. And so if we can do it partly with chloride channels and partly with other mechanisms, we may be able to get where we need to be. The bottom line is that we know we go from DNA to RNA to protein to symptoms in the way that we cause disease. And we've sort of gone exactly the opposite direction in how we've tried to cure it. So we've got continuous therapies treating the infection, the mucus, the inflammation. Now we're trying to affect the protein with CFTR modulators, potentiators, and correctors, things like Kalydeco and ivacaftor. Hopefully we'll get to a point where we can fix the RNA, and then hopefully some point get to that real goal of fixing the DNA, a permanent fix for CF. But to do that, we need everyone involved, okay? This is the number of patients we need involved in CF trials in order to get where we're hoping to be. So back here, it was maybe 1,000 a year. We need between 3,000 and 4,000 patients a year to participate in trials in order to make the progress that we're talking about. So please, be optimistic and participate in trials. Thank you.
Okay, whoa. There we go. All right. We do have about 10 minutes for questions. Again, due to time constraints, we ask that you limit your question to one per person. Please speak clearly into the microphone, which is set up in the middle of the room. Remember, a volunteer will adjust the mic for you, which they will clean between uses.
Morning.
There. All right. I'm on the conference committee, and I didn't hear anyone say up till now, for the new people especially, that on pages 41 through 44 in the back of your conference brochure is a glossary that will explain a lot of these terms that are being used, like bronchiectasis and that kind of thing. I thought that might help.
Thank you. One other thing I did want to mention between questions, and I meant to include this in my talk, there are a couple of really effective ways to find trials that you're eligible for. The CF Foundation's website, they've changed the website in the past year, so if you go to cff.org, they have now a very effective approach to finding what clinical trials you're eligible for. The other thing is that all trials that are going on under sort of FDA oversight, you can find in clinicaltrials.gov. So probably the CF Foundation, cff.org is a little bit more straightforward, but clinicaltrials.gov just has every single trial. If you type in CF, it'll just go on and on.
Certainly.
I'm so sorry to interrupt, and this is unfortunately not a question for you. I will turn it back over, but I just wanted to remind all the researchers in the room that at 10 o'clock, Salon 1, it is kicking off. Dr. Julie Desch is there now waiting for you, so thanks.
Aren't CF persons the most lovely persons in the world? And it's unfortunate that they're in a disease that is called an orphan drug disease. So my question is, will those drugs always remain so expensive that foundations have to pay the way?
I am not directly involved with the pharmaceutical industry, so I'm hard-pressed to answer that question exactly. But I think that's one of the advantages of having so many drugs being looked at, that right now there's no competition, and no competition means you set the price. But I think the more drugs we develop, the more competition will be, and hopefully the greater downward impact that'll have on the price. I know it's the expenses is incredible, and hopefully if the more drugs we have, I think the competition will cause pressure to bring it down to a more reasonable level, I hope.
Hi, yeah. I was just wondering if you could talk maybe for a couple seconds about any work being done on some of the more rare mutations, or how you think that's going to look in the future for those who don't have Delta F508 or
Yeah,
more
unfortunately,
comments.
I have this tendency to think I'm going to get through more than I can, and so actually the piece I jumped over, those 8 slides were the rare mutation slides. So there are a number of things for potential things for rare mutations. One is that ENaC, the sodium, the medication that's going to increase the flow through the sodium, the VX 371, I think is the number. That's going to be for any mutation. So, because it doesn't affect the chloride channel, it actually affects a different channel that is probably normal. And if we can just inhibit it, that'll probably provide benefit for all patients, because you don't need any channel at all. You can have no CFTR, and if you can impact the ENaC, that sodium channel, that should provide benefit, at least theoretically. There's sometimes a jump between theoretically and actually, but there's good reason to think that it may be effective. They're looking at atalurin for people that have the nonsense mutation. So the nonsense mutation, so you form your DNA, you have your DNA, you form a full-length RNA, and then you're supposed to form a full-length protein, a piece of, if you're knitting that piece of yarn that's long enough to make your sweater. With the nonsense mutation, what happens is they cut the yarn in half. You only get half a piece of yarn, so you only got half a sweater. So the atalurin helps you, blocks a scissor and lets you make the full-length message and full-length protein. And the original studies with atalurin, it was really weird. Sometimes it looked like it worked great, and sometimes it looked like it didn't work at all. And it turns out that tobramycin probably inhibits the function of atalurin. And for reasons that actually make sense, but are too complicated to talk about. But it isn't just a sort of, that's weird. It's like, oh, of course it did. And so they're now doing a trial looking at atalurin in patients that are not on tobramycin. And we're optimistic. But really what we're probably looking at is RNA and DNA fixes for those rare mutations. Actually, I don't know if you were able to hear Matt Proteus' talk, but that's Portis's talk. I mean, that's really the answer for the rare mutations, is replacing the gene. And the CRISPR that he was talking about, there is some amazing work being done to think that this is no longer science fiction. This is going to be reality.
So I have a question. I'm very interested in this VX371, which you were just talking about. But my question is, we've spent a lot of time hearing over the years about the chloride channel, and why all of a sudden are people now looking at the sodium channel, which seems like they're partners in balancing the fluid in the airways, and I was just curious.
So we've been.
What you think?
We've been actually, we being scientists, I like to, at least I'm on the edge of that. We've been looking at the sodium channel for a long time. There's actually a drug called amiloride that has a similar effect, but not as strong on the sodium channel. And they were looking at that at maybe 10 or 15 years ago. And there were even some trials in amiloride. So there's been some understanding of the sodium channel, but it may be the fact that there are now agents available. It may be that we're developing a greater understanding of the pathogenesis. I mean, up until 5 or 10 years ago, we weren't really totally sure about that water layer question. There were a bunch of, some people thought it was the concentration of the electrolytes, some people thought it was the height of the water layer. There were questions about pH of the water layer. So it's only recently that sort of making that water layer is the goal. And so that suddenly makes trying to inhibit the sodium channel more rational. And the other thing, it may be we finally have a drug that can do it. You know, we might think it's a good idea, but if there's no drug, it just sits as a good idea.
Thank you.
Hi there. My name is Emily Godfrey, and I am a family physician, faculty member at the University of Washington, Seattle. I'm also a reproductive health specialist, and I just want to say and thank you so much for a very understandable presentation about really what CF is, because clearly it's not my area of expertise, and I'm sure people are wondering, well, why am I here? I'm partly here because I'm actually very interested in, I have grant funding to engage women who have CF to talk about, now that they're living through the reproductive years, to really talk about what aspects are important for us to be looking at and thinking about for women who are living through the reproductive years. So if you're interested, please feel free to approach me and let me know. But my question is, the CFTR modulators, I am aware, has been approved as a Category B drug during pregnancy. And I also understand that while women were in these trials, women were asked to be using a form of contraception and not get pregnant. And so I'm kind of curious how the FDA came up with that kind of safety mechanism around the FTR modulators.
We'll start with I don't know. I mean, pretty much all trials demand contraception until there's until there's clear information about the risks with pregnancy. I think with the Category B, I suspect that it's largely related to animal data, that there was no danger signal in animal data even going to very large concentrations. I think there is a handful of pregnancies that have occurred on either ivacaftor or lumacaftor, and so I'm sure that they're following those closely. But I think that it got to my knowledge, it got a Category B based on animal data, but I don't know that for a fact.
Hi. I'm the one that we have the newborn baby. Yeah. So what I'm finding is it's hard to find other people that are in our situation that's got the newborns. Most of people I met have older children, which is so grateful because that gives us hope. My baby's got the type 1 mutation and the type 2 mutation. So from what I understand is that type 1, he doesn't get any water. And then type 2 is there, but it doesn't get through. So I'm confused as far as, is there treatment for him at this age that we should be looking at, or do they have treatment? Because he just gets the vitamins, the ranitidine, salt, and the enzymes. So I'm thinking, I'm not hearing any medications that sounds like it addresses his water level.
So right now there aren't. But you're saying that, if I understand, they have one of the genes is one of those type 1 mutations, and the other is a type 2?
Yeah, and the F508.
So they do have a copy of Delta F508?
Yes.
Yeah. So one of our hopes with this VX661, so the Orkambi only works in people that have 2 copies of Delta F508. But we're hoping, and we don't know this yet, but the studies are looking at people that we're hoping it's a more potent drug, and that would even help people that have just 1 copy of Delta F508. So that's one possibility. Also looking at things like that, the medication that increases that inhibits the sodium channel. So those drugs that it won't matter what mutation they have, that's potentially applicable. These are all drugs that are still in trials. And the other thing is that typically they will do the trials in adults, or it's either 18 above or 12 and above. People are very nervous about doing trials in babies. So we make sure that the drug is safe in adults and older teens, and then kids, and then finally they look at it in infants, because we want to make sure. I mean, if infants are fragile, and we want to make sure that what we're doing is safe, and so unfortunately it's always a little bit longer before we have the information for the infants.
Okay, thank you.
You're welcome. Thank you.
Thank you, Dr. Dunitz.